All right, so this made me do a little bit of a deep dive. Let's take a look at some of these case studies. So this particular case study, go ahead and check it out yourself. Patient was laid down flat with regular gauze, was applied pressure at the site for about 5 minutes. Patient had a hard time tolerating Trendelenburg, so I'm assuming she probably had a hard time with supine as well. And so they finally sit her up immediately after the 5 minutes. And during the removal, they asked her to exhale, which I wonder if there's an effect there. We'll talk about that later. Right, again, same thing. Patient was laid down flat during the removal, was told to hold their breath upon the removal, and then after about 5 minutes of pressure, patient was sat up, and of course, non-occlusive dressing, just regular gauze, was placed, and the patient started to develop symptoms of pulmonary embolism after sitting up. All right, so this is a young 27-year-old who had a CVC. They sat him up and then removed it. The patient was discharged after 30 minutes and then readmitted to the ED for shortness of breath. He said that he had whistling noise during that onset of symptoms. That's crazy. And of course, the non-occlusive dressing was applied. This one is wild. A fibrin sheath as a portal for... Hold on, check this sentence out. Vein to dermis fistula. Holy crap. Now, the story goes that the CVC was already poorly placed. Look at that piece of shit placement there. Not even in the SVC. So check out the article. Basically, because the non-occlusive dressing was used, for hours after removal, there was a fistula that developed because of the fibrin sheath, is what they're guessing. And only until after the occlusive dressing was placed was there an actual closure of that fistula, which is wild. So that's when the hospital implemented a 24 to 72 hour minimum occlusive dressing application. So this is why I prefer laying them down flat and keeping them flat for a whole hour after the removal. I'd rather them bleed. I can manage bleeding more easily than I can manage an air embolism. So laying them down flat will help to fill that vein to dermis fistula. that's where the air is ingressing. Now, if you're like, hey, my attending says to do it, I don't want to argue with my attending, I don't want to get in trouble, I'm still just a resident or just a fellow, fine. What I do is I skin glue the crap out of that site. What better than gluing it closed? So I glue it with the whole vial amount of glue, make sure that's in there really good, and then seal the whole area, even the outer edges of that glue, with petroleum jelly or antibiotic ointment, and then put occlusive dressing on top. This will really, really ensure that there is no ingress of air, whether they're laying down or sitting up. Again, it doesn't matter as long as the air doesn't go into the veins.